Good morning, everyone. I'm Dr. Jennifer Sullivan, the Secretary of the Indiana Family and Social Services Administration. I'm joined by Dr. Dan Rusyniak, our Chief Medical Officer for FSSA as well. Thank you so much for joining us this morning. We're really excited to be with you. I wanted to give you just a couple of items for our agenda today. We have about 20 minutes of a presentation for you this morning, and then we'll save 20 minutes for Q&A at the end of that. We do have a hard stop at 8:40 because Dr. Dan is earning his line at the his place in line at the pearly gates. He is going to vaccinate nuns this afternoon, so we'll get him out the door so he doesn't miss that incredible opportunity. I'm really excited to be here in this moment in time, and also grateful to see the initiation of a thoughtful plan to enhance how and where Hoosiers age after 4 years of multi-agency, multi-stakeholder work and input. Understanding the complexity of long-term services and support systems and finance has been a priority for us since day one 4 years ago. We have been hampered from a comprehensive plan by a pre-existing managed care moratorium for this group of people, while more than 80% of Medicaid when we started in Indiana is actually already in managed care. And so this effort has been galvanized by COVID with a demand by Hoosiers for a choice on where and how they should age. This is the right time and the right place for collaboration and meaningful change. Next slide, please. Governor Holcomb, in his State of the State address, really helped us kick off the initiation of this multi-agency, multi-stakeholder, multi-division program. So saying that our elders need to have the ability to age where they choose. This means that we need quality institutional nursing care, but we also need an expanded workforce to do home health, to do home and community-based services, and that our Medicaid services need to respond to the culture change of what people are asking us to do. Next slide, please. I'll now kick it over to Dan, who has become famous for his work in COVID for long-term care, to talk to us about what we've been doing in long-term care settings for the COVID response.
Thanks, Jen. So from the first cases of COVID in the US, we understood the risk that this pandemic posed to older Hoosiers who lived in congregate settings. The very congregate nature of these facilities puts them at an increased risk of both contracting COVID-19 and their age and comorbid illnesses put them at an increased risk of being hospitalized and dying from it. So in addition to the work alongside the Department of Health to reduce outbreaks and deaths in nursing homes, we and FSSA have engaged in work to keep more individuals at home. As part of the public health emergency, we sought and were granted from CMS the approval to run an expedited eligibility pilot for home and community-based services. The program allows providers to make much faster determinations on whether someone is eligible to receive home and community services. So what used to take 4 to 6 weeks can now be done in 72 hours or less. And since starting this, we've been able to rapidly approve over 600 applications for services. We've also expanded the number of individuals who can make these determinations. So it's now not just the area agencies on aging, but also assisted living facilities, adult day providers, and now even some hospitals. Indiana was seeing the same trends in the reduced number of nursing home admissions that other states in response to this pandemic. So to allow more individuals to stay home really requires supporting the largest unpaid workforce in healthcare, and that is families. So we reached out to ARP to help with communicating our structured family caregiver program. This is a program that allows families who qualify to get financial support to take on a caregiving role for a family member who would otherwise qualify for a nursing home. We're also engaging in a survey of family caregivers to better understand what their needs and barriers are to caring for their loved ones at home. And lastly, in partnership with the Department of Health, we were the first state to recognize the role of essential family caregivers in assisted living and skilled nursing homes. This allowed for families to continue to provide the services they did prior to the pandemic, during and after as well. These programs, along with our Money Follows the Person grant, have helped us not only keep more individuals at home during the pandemic, but have better informed us on how we need to reform our long-term service and support system.
So every other year, the AARP does a survey across the country of how people are doing in quality for how people age across the long-term services and support spectrum. When we started 4 years ago, Indiana ranked 51st. We have made some progress in this, and our 2020 ranking was 44th. A lot of that has to do with the work that's been done within the Medicaid program around affordability and access improvements, and then also improvements for quality of life and quality of care. We still have a long way to go to continue that upward trajectory within quality, specifically in how and where people are able to choose the setting in which they age. Additionally, we haven't made any progress yet, but since COVID, we certainly have, in supporting family caregivers to keep their loved ones at home. Given these tools and given these rankings, we have designed our program around enhanced quality and are really proud of the enhanced partnership that we have with the AARP. Next slide. It goes without saying that there's a reason to reform, but let me just break down the whys of Indiana's long-term services and supports system reform. First and foremost is choice. Hoosiers want to age at home. Across the country, 75% of people over 50 prefer to age in a home-like setting. But in Indiana, only 45% of Hoosiers who qualify for Medicaid are currently aging at home. This means that we haven't done the right thing in allowing that choice to be possible for people in Indiana. And so we have to prioritize that. The second is cost. As the population of aging Hoosiers continues to grow over the next 2 decades, we have a lot of work to do to make sure that we have the right infrastructure to care for them. Indiana has about 2% of the US population, but over 3% of nursing facilities. And so we need to balance that and make sure that we have enough home-based settings as well. In addition, long-term services and support members are about 4% of our Medicaid population. We have about 1.9 million members in Medicaid. And yet nearly a third of the spend. Only 19% of our long-term care spend goes to home and community-based services. We call this process of moving that number rebalancing. And so hitting the right ratio of where our spend goes within Medicaid. And then last, but certainly not least, is quality. Hoosiers deserve the best care. Our scorecard is our true north of where we need to go. And currently our long-term services and supports are not as coordinated as they need to be. And this comprehensive plan that we're about to talk to you about really addresses all 3 of these meaningful reasons. Next slide. Also, just to show everyone, we're not done with the growing aging population, still 2 decades of growth. So we have to respond now in order to meet the demands for the future. Next slide. This is a slide on that word we talked about a minute ago, rebalancing. We're talking about money here, not population, but the gold standard is what we call a 60-40 split of the amount of spend that we have that goes toward home and community-based services versus the proportion that goes to institutional. 60 for home and 40 for institutional care. Indiana hasn't kept up with the US in rebalancing to hit that goal. And our plan will be to continue to support moving that toward that gold standard of 60-40 split in order to stabilize our budget and also improve quality. Next slide. So I'm going to turn it over to Dan to talk about our 4-part plan.
Thanks. So how do we get there? First, we need to decide where there is. And since we know from an AARP survey that when asked, 75% of people over the age of 50 would prefer to age at home, we've set out the bold objective to create a long-term service and support system that gives Hoosiers the chance to do this. Our objective is that 75% of new members would live and receive those services in a home and community-based setting. This system will have the added benefit of helping us right-size our spending so that 50% of the money spent on long-term services and supports goes to keeping people in their home. Now, the way we get there is by achieving 4 key and interrelated results. First, we make sure that when older adults need home services, they can get them fast within 72 hours. 2, we help Medicaid members navigate the complex LTSS system through a managed care system that will make sure that they're getting the right care from the right provider in the right environment at the right time. And this is what managed care has done in countless other states with improved outcomes and lower costs. We make sure that the system we design is more than changing how we pay for care. Rather, it's assuring that the way we pay results in the kind of outcomes we all want to see for our friends and family. To do this, we'll link provider payments to outcomes through a value-based purchasing system. Lastly, We need to make sure that we as the state have the data we need to assure that the system is working as designed. Right now, across the continuum of LTSS, a person could end up in 7 or 8 different databases, but there's no way of connecting that individual across these systems. So we can't look at someone and say, what are all the services they're getting? And more importantly, what services are they not getting but should be? Likewise, we can't easily compare providers to see who are the best and the worst performers, and we can't easily compare facilities on the outcomes we want to know about. So our fourth key result is to have an integrated LTSS data system. Next slide. So let me take you through how our current system works and then how our reforms will change that. So here's the scenario. A 70-year-old grandmother who has Medicaid and Medicare is able to stay at home because her son is able to come by and help with meals and jobs around the house. Unfortunately, she falls and breaks her hip. So she goes to the hospital, and after her surgery, her and her family have to make a difficult choice. Can she stay at home, where she would prefer to, or will it be too difficult and too much of a burden for her family, and therefore she should go to a nursing home? In our current system, it would take about 48 hours to find out if she's eligible and then to get her into a nursing home, where she could then get services. We know, however, that for some individuals, even a short stay in a nursing home can result in a long stay. The other option would be for her to go home. That, however, requires her and her son to figure out what she's eligible for and what she needs. And this can take 6 weeks or more. And during that time, her son would have to leave his job, become a full-time caregiver, something neither grandma nor the son wants. So the current system just takes too long to get home services, is too difficult to navigate, and too burdensome on family caregivers. Next slide. Now let me take you through how we're proposing our LTSS reforms would change this scenario. Now grandma falls, breaks her hip, but now she and her family have a choice. By calling the managed care company that they have, they get help with coordination of services. The managed care entity is incentivized to get to the outcome that grandma and the state want. They're able to get their home services faster, and her son and family get the supports that they need to allow them to continue to support her, but not have to dramatically change their life in doing so. This new system gets home services faster, helps coordinate the care that's needed, and provides the supports to sustain it for both grandma and her family. Next slide.
The good news, thinking about managed long-term services and supports, is that 25 states do this already. We have many examples over several decades of the outcomes that we're looking for. Every managed care service and support program in every state is unique. They design it how they want it, and Indiana will be no different. We have lots of examples of states that have done this well, and we have other examples of states that have stumbled and faltered, and that gives us great examples of what to avoid and what to capitalize on. Indiana is very excited about working with multiple partners across the long-term care industry, home and community-based services industry, home health, hospital systems, minority health, rural health, hospital association, and patients and families themselves to design what Indiana's version of managed long-term services and supports look like. To be clear, this is not just a payment mechanism. This is providing care coordination for families across the multiple different places where they might be. It means that transitions between hospital to home to rehab to long-term care and back are actually coordinated in a central manner rather than being fragmented and really difficult to navigate for families. This is truly co-designed for patients and by patients. Next slide. We have some next steps that we are already initiating. The first and foremost is that our expedited eligibility pilot in home and community-based services that Dan talked about will be expanded. We've already expanded it 3 times, and it has been wildly popular in the 10 areas where we are using it now. We will expand that continuously through the public health emergency and then develop a post-public health emergency expedited eligibility process that will just define how we do business and level the playing field between choice of where people choose to age. Let me also be clear that we will always need quality institutional nursing home care. This is important to support everyone, and we want to make sure that everyone has access to these types of services across Indiana. We really just want to make sure that the entire continuum is strong and supports quality. We will also continue to focus with our partners at the AARP on caregiver supports, and Indiana is leading the way in this effort. We will also begin, starting on Monday, to co-design a managed long-term services and supports program, with a goal in the spring to put out a request for information for increased stakeholder input on what this program design looks like for Indiana. Our stakeholder conversations to increase regular opportunities for dialogue have already begun, and we can't wait to continue them. And just like everything else that we do at FSSA, we do this together. Stakeholder engagement is critical to success, not only in the short term, but the long term. We're excited for the culture that we have in this moment in time to be doing this important work to make sure that our loved ones, my parents, my grandparents, and yours, have the ability to age where they wish in the right way, at the right time, in the right place. Thank you so much for joining us this morning, and we're excited to take questions. And thanks, Dan.
Thank you, Jen.
All right, this is Jim Gavin with Indiana Family and Social Services Administration. We'll begin with Whitney Downard.
Good morning, Dr. Dan and Dr. Sullivan.
Good morning, Whitney.
So my biggest question, I have a second question, but my first question is really going to be on what exactly can Indiana do to increase the workforce? Like you said, we need more home aides and nurses and all sorts, not only in our nursing homes, but to support these community-based and home-based services. How are we going to increase that pipeline of employees?
I'm going to repeat your question back to you. There was a couple of cutouts. Basically, you're asking about how do we make sure that our workforce is sufficient to meet this need? Increasing the pipeline, et cetera. Great. So Dan says this all the time. He's been really on the front line working with nursing homes, in particular assisted living, and then also talking with folks who are getting home and community-based services. And the enhanced coordination of this system and really kind of designing a system that we want and then paying for that system is really critical. And increasing the workforce over the long haul by making sure that we're paying for that quality and really directing this entirety of our payments toward actual patient care is how we increase the pipeline for folks coming into these services. But one of the things that we can do in the short term is what we've been focused on across both our Division of Aging and Indiana Medicaid and also the Department of Health is that support for family caregivers. They're already there. They're already doing incredible work. And so we enhance the ability to have people at home or even have folks stay a little bit longer in an assisted living type setting by letting their families do what they want to do and then assisting them with those home health aides and other activities of daily living supports that they need.
And then my second question is about that family caregiver. What kind of supports are you talking about? Are we talking about financial, emotional, physical? What kind of supports are we talking about here?
Great question. I know Dan will be very excited to answer this one.
Yeah, so it's a little bit of all the above, but also education. So right now, if you're taking care of your loved one at home, you may not have a comprehensive educational program that helps you understand what their needs are and what the best evidence is in trying to provide for it. So there needs to be good educational systems for people who are caring for their loved ones at homes. There are some financial support structures in place currently in our structured family caregiver program, and we need to make sure that those who qualify understand that program and can access it as well. And also having in a managed care system, a single entity or a single person that you can call with questions and help is also going to be incredibly helpful. And lastly, we need to reach out to caregivers, and we're doing that through our survey to ask them, what are your needs? What are the things right now that prevent you from caring for somebody at home or make it challenging? And then as we understand those needs better, that's where we'll reach out to our partners in managed care and our home and community-based providers to innovate, to figure out how do we support individuals with those needs? How do we create programs that make it easier to care for loved ones at home?
Some of those things, to answer your question with a little bit more granularity, are as easy as helping to finance the redesign of a bathroom so that an individual can bathe at home without having to be picked up by a daughter who just can't do that. Those physical changes in the infrastructure of where someone lives, actually in the whole scheme of things, are really inexpensive as compared to an enhanced level of care that would be needed to do those activities of daily living. It's things like installing a ramp that's safe in the front of a house so that a wheelchair or a walker can be used more safely. The things we always point to are things like moving rugs, but moving rugs that the individual wants us to move so that they don't fall, but not dictating to them what their home looks like. It's really this co-design with someone of how we keep them safe and make it easier for their family caregivers to do what they need to do.
Okay. Our next question will be from Nikki Kelly.
Hi, I had a couple questions. You said 60/40 is the gold standard, so I wonder where we're at now. And then also, the moratorium, does this mean you need the legislature to take that back, or how do we end that?
Great questions, Nikki. So we are inching closer and closer over the last 4 years to that 60/40. The goal for this particular program is that we actually split right down the middle. We get to 50-50 split, and that will actually achieve budget neutrality in this population if we spend 50% on home and community-based services and the other 50% on institutional services. If we move further beyond that, then we really start to see some cost savings in this space. But right now, we're really just looking to get to that 50-50, and we're edging more closely toward it. But I think this, again, comprehensive reform and paying for the system that we want is really essential. As far as the managed care moratorium goes, that has been in place all 4 years and has been renewed several times since the Holcomb administration. It does expire at the end of this year. And so our hope is that by presenting an option to the General Assembly that we have the opportunity to do, and actually the regulatory authority within FSSA to do all of these items that we've talked about today, is that moratorium could just sunset and then not be renewed.
All right, our next question is from Emily Hopkins.
Hello, can you hear me?
Yeah.
Hi, good morning. Thank you guys for taking the time this morning. I have about 20 questions, but I'll spare you a bit. My first question is, what happens with the county hospitals if the upper payment limit funds that have traditionally come from nursing homes go away? It's my understanding that through managed care, those would no longer be accessible through the non-state government entities that are currently operating.
So great question. And actually that isn't the case. So let me just restate your question. We're talking about managed long-term services and supports, and then also the supplemental payment program that goes is a partnership between critical access county hospitals and nearly all of our nursing homes in Indiana. Those two programs can coexist. But when you look at those 4 parts of the plan that Dan put together, number 2 is managed care for care coordination. And number 3 is really transforming that UPL or supplemental payment program that takes us from Medicaid to Medicare rates into a value-based purchasing program. What that allows us to do is supplement our funding to pay for the quality initiatives that we decide as a group, not we as the state, but we collectively in this design process decide are important. And so there are multiple other states that have both utilized the supplemental payment program and have managed care. They are not mutually exclusive. And so that's why we're bringing them together really as the tools and the drivers in finance for the system that we wish to design.
Thank you. And 2 other questions. One, when can Hoosiers expect to access care through this managed care program if all goes well and to plan? And in the meantime, what does that mean for the current status of quality? Are there ways to increase that quality before we get to that ideal managed care place?
What a fantastic question. Thank you so much. So just because we have a long-term plan and a very thoughtful timeline that we will obviously build with stakeholders doesn't mean that we can't do things now. That's the beauty of the work that we've been doing with COVID. And Dan, I think you can talk about a little bit about some of the quality measures that we're already working on that we will not stop, because you're right, we can't have this in front of us and not continue to work as we move that forward. The process, I'll turn it over to you in just a second for that. The process for this is multiple, and all of those interactions are really critical. We talked about putting out a request for information in the spring, and then taking that information and then putting that into a format that we would then use to build out what we want that managed care service to look like. That process takes quite a bit of time. And so it allows us actually the time to really, again, build up workforce, build up family caregiver supports, talk about the quality metrics that we want to incentivize, and do that work while we are waiting for managed care to come into place over the next several years. Dan?
Yeah, and already we're starting in discussions, and we'll be reaching out with stakeholders as well to identify what are the outcomes and what are the quality measures that we want, and how do we start measuring those now? And by measuring those, then how do we influence them? So, for instance, we know that two of the things that in the home and community-based service that tend to make it difficult to keep loved ones at home, number one is essential family caregiver or family caregiver support. So like we mentioned, we'll be collecting some information from families to identify what are those difficulties, and then how do we start to collect and measure that information so that we can design a system and measure the change. We also know that sometimes staying in an individual home can be a challenge, and so we'll be doing work with others to figure out how do we assess that, how do we measure it, and then how do we build programs to innovate already in individuals' homes. On the other side of things, in the institutional side, we have a small value-based purchasing program right now that we use with the programs, but we'll be looking at really engaging more with our stakeholders to determine what are the outcomes in institutional settings that matter. So staffing or staffing ratios, for instance, falls, bed sores, et cetera. Some of the stuff that we collect now, but collecting it in a way that I think is going to better inform us and already allow us to use the tools we currently have to try to move towards outcomes even before we get to an MLTSS system. And the only other thing I'll mention is that through our expedited eligibility program, we're also collecting information right now about how quickly somebody can get home and services, and then after they get through the eligibility, how quickly before they can be delivered. And so that information is also really critical for us, will help us understand a little bit the roadblocks in getting people fast services. And so along the way, as we build this, we'll be looking to improve that as well.
Our next question is from Eric Berman.
Morning, Eric.
Morning, guys. I also have like 20 questions, but I'll hold myself to a couple. First, Dr. Dan, I wanted to go back to the flow chart of grandma breaks her hip. Instead of the process of care, walk me through the process of process. So the state would have a single managed care provider, the equivalent of Anthem or MCare or what have you, or multiple providers. You as the family caregiver go to them, and then they assign a home health care worker. How does the process work in setting this up?
Yeah, so I'll talk a little bit about in terms of how many managed care entities they would go. It'll depend a little bit on the program design and how many individuals will qualify for it. So I don't have an exact number, but as we build this out, we'll be able to get that information. One of the things that we didn't say, but is really critical, is that, you know, this individual in the scenario has both Medicare and Medicaid. And those two systems, while both providing services, really are often not well coordinated together. So now all of a sudden you've got a single point of contact who is also the Medicare Advantage provider in most cases. So now you got one entity who's both overseeing the Medicaid and the Medicare aspects. And so now it's not as disjointed. So now you don't have to think about, well, Medicare is going to cover the hospitalization, but if they now need a nursing home, that's going to go to Medicaid, and when does it switch over? And how do we get that approval process and the transfers? So now you've got one company essentially who's managing both sides of those things. And now is it would make sense, incentivized to make sure that that individual really gets the best care in the location that they want, and also being at home if they're able to stay so is a more financially beneficial for both the state and the managed care entities.
And basically that gatekeeper says, okay, here's your list of providers for what you need, decide who you need.
Yeah, and we'll, as we design this, you know, we'll have our AAAs at the table as other, and we'll look at some other states. They're all going to still have a role because they do this well already in the care coordination. So a lot of it's going to be for the managed care entities. How do you assemble the pieces that are in place right now into a really efficient, easy to use system. And instead of having the individual provider, the son or the individual having to try to figure out which service, they have one number they can call potentially who understands the system, understands the different parts of it, and then can direct them to what they need.
All right, our next question is from Brandon Smith.
Morning, Dr. Sullivan, Dr. Dan.
Good morning.
I have two questions. The first is about money. You talked about rebalancing the spend, but in the short term, when we're talking about expanding the expedited eligibility, building out the infrastructure of that workforce, are we going to have to spend more money up front in order to get that stuff done? Or can we do it all within sort of existing dollars?
Well, so far, by doing expedited eligibility and using our teams in combination with an expanded group of people that can actually make this determination, so our area agencies on aging, assisted living, hospital settings, et cetera, and a team of people on our end that then go through those applications for expedited eligibility, we have the infrastructure in place to do it. We just needed the impetus to go ahead and put it in place, which happened under CMS direction during the public health emergency. We were given the opportunity to get that started early and are really thrilled to have the opportunity to do it now rather than wait to do it later, so that we have all of this information and data to show us where we need to grow, not only geographically, but in what type of services over time. Our spend in LTSS has increased every biennium since I've been here and for several predecessors. But we have, I think, sufficient funding to start to level off that increase over time by doing these things in a more coordinated way, more thoughtfully, and more efficiently.
Yeah, and the only thing I'll add is it does not take a lot because the cost of institutional care is so much greater than home care. You don't have to keep that many people out of institutional care to really offset the costs that would take to move to managed care. So I think a lot of things we're doing now will help, but to getting to that balance, even along the way, we're likely going to be budget neutral.
And then my second question kind of follows up on what Nikki asked earlier. Obviously, the moratorium sunsetting would be legislative, but are there any other things that you need the legislature to do to give you all of the authority and flexibility you need to implement this plan?
It's a great question. We do not. However, we are really glad to be partnering with multiple of our legislative colleagues that are interested in making sure that long-term services and supports in Indiana really support the needs of their constituents and stakeholders. Obviously, we all care about what this looks like. And so we have regular conversations about this process, but we don't need specific legislation in order to enact this plan.
Our next question is from Brock Turner.
Good morning, all. I have two questions as well. The first is just, what other states did you look at that, have similar programs that seem to be doing this well?
Well, our team, in collaboration with several groups that have been doing technical assistance with us for multiple years, have looked at all of them actually, but we have a couple that stand out as really successful and actually a long track record of doing MLTSS well. Arizona and Tennessee being two of those that really stand out with a long history. However, Indiana's program will not look just like Arizona or just like Tennessee, but different factors from each of those. We've also looked to other states that haven't done this particularly well, are now recovered and doing fine, but just those initial kind of hiccups out of the gate so that we make sure we get this done. We also, just as a quick reminder, Indiana Medicaid is largely already managed care. Over 80% of our Indiana Medicaid members are in a managed care program. And so we know what we do well. We know what we do well in a delicate population. Our Hoosier Care Connect program is for members who are age blind and disabled. And we work on quality measures within that managed care program currently. And so the idea of continuing to expand what Indiana does well within Indiana Medicaid to be really comprehensive and really patient-centered is key.
And then I know you said the gold standard was 60-40, at least in terms of what folks desire. The goal of this program is to get us to 50-50. Where are we at now? Just kind of wanted to follow up on Nikki's question.
So that number changes all the time. It actually is closer to 50-50 based on where we are in COVID than we were pre-pandemic. So because the culture across the country has seen decreased nursing home admissions over the last year and really incentivized families to keep members at home, we are not quite to the 50-50 yet, but we're getting closer and closer. We really would like to be over time at that gold standard of a 60-40 financial split.
Yeah, and I would add that, some states have even gotten to the 75 and 80-20 range. And so while that's not our target goal, over time, as you build this system, you can result in a lot more individuals being at home and much more of the spend being at home.
Our next question is from Kelly Renke.
Hi there. Good morning. Thank you for taking my question. 2 questions really quick. I know Dr. Dan, earlier you said that about 600 applications were approved through the pilot program with the help of CMS. Were there any reasons when applications were not approved, or are a majority of them approved through this program?
The vast majority have been approved. There are a few that were not, and they were all based on eligibility criteria.
Okay, that makes sense. And then just for clarification, I know for nursing homes right now, a family can go on CMS Nursing Home Compare. They can also look at inspection reports over ISDH. If families are interested in this home or community-based care, is there going to be some sort of system where they can review the care that they will get?
Yeah, I think that's a great question. And I think that's part of this integrated data system that we're talking about, right? And so building out dashboards that not only will inform us, but can also inform the public, I think is really key. And just to mention on the Compare site, so in addition to the work we're doing in FSSA and our stakeholders, we're also partnering with Department of Health. And so that's one of the offshoots of COVID, is that we really have worked hand in hand and really closely with them in trying to reduce spread and outbreaks in nursing homes. And through that have really, I think, strengthened our relationship. And so they'll be with us as well to make sure that the regulatory side of institutional care and the payment side are both kind of singing from the same songbook, so to speak.
Thank you.
All right, we only have about 2 minutes left. Emily Hopkins, I see your hand raised. Can you ask your question in 2 minutes?
Yes. So my last question, thank you for humoring me, is I believe there is at least a type of ban on managed care proposed the legislature right now. What happens to all of this if the ban or moratorium is extended?
Well, the good news about this plan that has been put together over a period of time is that all 4 of those elements that we discussed work very well together if we do them all. They really launch us really comprehensively toward a system and a payment mechanism that we think will really work for Indiana. On the other hand, the good news is each of them work independently. And so if the key result number 2 around managed care is not available to us, we can continue to do the work of expanding our expedited eligibility work. We can work on moving our UPL program into a value-based purchasing system, and then we can do the data integration that we need to do. We hope we have the opportunity to do all 4, but we can continue forward with all of it regardless.
You are out of time. We'll wrap things up this morning. Thank you very much for joining us, and thank you for your thoughtful questions.